Hello, very warm welcome to everyone. First of all, I would like to start with an apology for that delay. We had an unexpected technical issue, that is why we were running late. For all of you who have waited patiently, big thank you from me and welcome to you all. Good evening, Anisul. Good evening, 𝗓𝗲𝗃𝗍, especially 𝗓𝗲𝗃𝗍 who joined at 7 o'clock in the morning. I mean, in the 7 o'clock itself. And she has been waiting patiently. Thanks, 𝗓𝗲𝗃. Good evening, 𝗓𝗲𝗃. So first of all, let me introduce myself. I am Dr. Rohit Daniel, the orthopedics faculty at Arise. And today I'll be bringing you Arise Super30, where I'll be discussing the most important 30 MCQs that I expect that it will come in your upcoming exam. All right. And along with these 30 MCQs, what I will try and do is that I will try and discuss a few more important points that are related to these MCQs, which are again important for your exam. And I have spread out these MCQs in such a way that I would be able to cover the maximum amount of area or topics from orthopedics. All right. So just for checking sake, am I audible? If everything is audible, if there are no technical issues, then please give a thumbs up in your chat box, please. Is everything fine? Okay, thank you, 𝗓𝗲𝗃𝗍. So we'll start this session. So I want this to be an interactive session. So these are all standard questions. 90% of the questions are from previous year questions and what I've adapted from those questions. So this is going to be relatively easy for you. So please, if you know the answer, go ahead and type in the answers in the chat box. All right. So the first question, a 25-year-old male was involved in an RTA. He was brought to the casualty with complaints of pain in his right hip and inability to walk. On examination, his hip was flexed, adducted, and internally rotated. What is the probable diagnosis? Is it an anterior or posterior dislocation of hip, fracture neck of femur, or intertrochanteric fracture? What do you think the answer is? Very good, very good. Absolutely correct. Anisul and Punks, absolutely correct. You are absolutely correct. The answer is posterior dislocation of hip, isn't it? The key to the answer here is what? The deformity. Evangeline, absolutely correct. Anisul again, absolutely correct. The key to diagnosis here is the deformity. Flexion, adduction, and internal rotation. Dislocations of hip are very, very important, very often asked for your FMGE exam. Now let's discuss the deformities that we see in each of these options. In anterior dislocation, we get flexion, abduction, and external rotation. In posterior dislocation, we get flexion, adduction, and internal rotation. In fracture neck of femur, we get slight external rotation. And intertrochanteric fracture, we get severe external rotation, deformity. So just by looking at the deformity of flexion, adduction, internal rotation, we know that the answer is posterior dislocation of hip. Now, this is a very, very important table which gives the differences between the posterior and anterior dislocation. I have written the posterior and dislocation column first. Why? Because that is the most common dislocation of hip. Okay. It is the most common hip dislocation and it usually is associated with an RTA, road traffic accident, especially a dashboard injury. The deformity is flexion, adduction, internal rotation. There will be shortening of the limb, and because the femoral head goes posteriorly into the gluteal region, what will happen? It can press against the sciatic nerve and cause a sciatic nerve damage. So these two things, the deformity and the nerve injury, are very, very important. Again, what about the anterior dislocation? It is rarer and it usually occurs as a result of a fall from height. The deformity is flexion, abduction, external rotation. There will be lengthening of the limb. And because the femoral head dislocates anteriorly into the femoral triangle or the 𝗲𝗏𝗃 triangle, the femoral nerve is at risk. Okay. So this table is very, very important for your exam. Now, rarely they can give you an X-ray and ask you to assess which is an anterior or posterior dislocation. Again, the concept is just the same. Okay. So in posterior dislocation, we have flexion, adduction, and internal rotation. In anterior dislocation, we have flexion, abduction, and external rotation. The key thing that you have to note here is this: adduction and abduction. Just look at this X-ray and tell me what is the deformity that you see here. Can anyone tell me what is the deformity of the hip? You can see that the hip is dislocated, but look at the shaft of femur. It is going towards the midline. Is it adduction or abduction? Is it adduction or abduction? Yes, very good. This is adduction. Correct. Absolutely correct. This is adduction. Because it is adduction, it is a posterior dislocation. Okay. Here it is just the opposite. You can see that the femoris is going in abduction. It is abducted. It is going away from the midline. So here it is abduction. So this is a anterior dislocation. So even if you get an X-ray, don't have to worry. Just by looking at the attitude or deformity, you can clearly get to the answer. Okay. So this is a very, very important question. Next question. A 49-year-old male presents with history of fall and injury to forearm. His X-ray is given below. What is the treatment of choice? Below elbow cast, above elbow cast, open reduction plate fixation, or tension band bearing. Can you tell me the answer? First and foremost, you have to identify the X-ray that is shown here. What fracture is this? Can you tell me what fracture is this? Can you tell me what fracture is this? If you see here, you can see that this is the wrist joint, isn't it? It is the wrist joint, and this bone which is close to the wrist is broken. That is your radius. And where is the radius broken? It is in the distal third. In the distal third area, the radius is fractured. And you can see that there is no connection between the radius and the ulnar. This means that the distal radio-ulnar joint is dislocated. So what do you call the combination of distal radius fracture and a distal radio-ulnar joint dislocation? What fracture is this? Very good. Nakma, RS, Moramba, Ritika, Sakshi, absolutely correct. This is your 𝗟𝗟𝗃𝗃 fracture. 𝗟𝗟𝗃𝗃 fracture. 𝗟𝗟𝗃𝗃 fracture is important because it is called as a fracture of necessity. What does that mean? This means that this fracture can be treated only through surgery. Cannot be treated by any other method. Cannot be treated by any cast. You have to do a surgery, and the surgery that we do is, yes, Anisul, absolutely correct. We do open reduction and plate fixation. We do open reduction and plate fixation, not tension band bearing. We do tension band bearing in some other fracture, which we will discuss later. Okay. So whenever we talk about 𝗟𝗟𝗃𝗃 fracture, another fracture usually causes confusion. That is this X-ray. Again, usually asked as a question in your FMGE. Can you identify this fracture? It is kind of an opposite to that of your 𝗟𝗟𝗃𝗃 fracture. What fracture is this? Here, if you see, there is a fracture of the ulna. Fracture of the ulna in the proximal third with the dislocation of the radial head. What do you call this fracture? Yes, Anisul, Joanne, Sakshi, absolutely correct. This is your Monteggia fracture. Monteggia fracture. Okay. Now, Monteggia fracture, they will ask you this X-ray for diagnosis. The second thing they can ask you is which is the nerve injury that is involved in Monteggia fracture. Can anyone tell me the nerve injury that is seen in Monteggia fracture? A nerve which passes very close to the head and neck of radius can get injured. What nerve is that? Can anyone tell me? Nakma, absolutely correct. Super answer. That is your posterior introitious nerve. Okay. Posterior introitious nerve can get injured. Remember, posterior introitious nerve is a motor branch of the radial nerve. It supplies the dorsiflexors of your fingers. And if the pin is paralyzed, you get something called as finger drop. You get something called as finger drop. Okay. Posterior introitious nerve palsy will cause finger drop. This much you need to know about Monteggia fracture. Now let's look at the next question. See, if you have any doubts, don't worry. At the end of the session, we'll keep around 10-15 minutes for clearing your doubts. You can just write it in a piece of paper or you can scribble it somewhere. At the end of the session, we can discuss any doubts. Okay. Next question. A 35-year-old female presents after RTA with an injury to her knee. The X-ray is shown below. What is the treatment of choice? Again, a previous year question, isn't it? But very often asked question. Which bone is fractured? This is an X-ray of the knee joint. This is our femur. This is the tibia. And this is the patella. And what has happened to the patella? Patella is fractured, isn't it? Absolutely correct. Anisul, Sakshi, RS, Moramba, absolutely correct. This is a transverse fracture of patella and you treat it by tension band wiring. Very, very important. Okay. Tension band wiring. What is tension band wiring? This X-ray shows tension band wiring where this is the patella and you have the fracture like this. We fix it with K wires and then we use a stainless steel wire and tie it in a figure of 8 fashion to fix it. This is your tension band wiring. There is one other fracture in which we can use tension band wiring, which is olecranon fracture. Olecranon fracture. Okay. Olecranon fracture also we can use tension band wiring. Anyway, patella fractures can be treated by 3 methods. It depends upon the pattern of fracture. If it is an undisplaced fracture, you can put a cast like this, which is called a cylinder cast or a tube cast because it is cylindrical in shape. That is for undisplaced fracture. But if you get a displaced fracture, like you see in this X-ray, you'll do a tension band wiring. And sometimes, rarely, the patella can be completely shattered, completely destroyed. It is made up of multiple tiny pieces which cannot be fixed. In that case, you have to excise the patella and repair the patella tendon. And this is what we call as patellectomy. So remember the 3 procedures. Most importantly, remember tension band wiring. All right. Moving forward. Next question. A patient suffers a knee injury and after the knee injury, there is a foot drop. Which of the following fractures can result in this problem? Can anyone tell the answer here? Can a fracture neck of fibula, fracture medial tibial condyle, femoral condyle, or the patella fracture? Which can result in a foot drop? Can anyone tell me? First of all, what causes foot drop? Foot drop means what? The patient is unable to dorsiflex the foot, isn't it? So the dorsiflexors of the foot are paralyzed. And which nerve supplies the dorsiflexors of the foot? It is supplied by the common peroneal nerve. Common peroneal nerve. And the common peroneal nerve winds around a particular bony prominence. Can anyone tell me that? What area does the common peroneal nerve wind around? It winds around the neck of fibula. It winds around the neck of fibula. So this is your picture here. You can see the common peroneal nerve winding around the neck of fibula. So obviously you get a fracture there. The common peroneal nerve can also get injured. Okay. So the answer is fracture neck of fibula. Fracture neck of fibula. So you need to learn all your nerve injuries. Okay. For your exam, there will be at least 2 or 3 questions based on nerve injuries from both anatomy as well as orthopedics. So this is very, very important topic. Don't worry, we'll be rehearsing some more questions later. Okay. So other fractures such as the fracture of the patella, medial tibial condyle, lateral femoral condyle, these won't cause any injury to the common peroneal nerve. Now, what is this splint? This is your foot drop splint. Foot drop splint, which is used for treating foot drops. Okay. Now, this is an important question. What do you call the gait in a patient with foot drop? Patients with foot drop will walk with an abnormal gait. What is it? Can you tell? Can you tell me the answer? What is the abnormal gait? This is called the high stepping gait. High stepping gait. Okay. High stepping gait. Okay. So remember, The gait, abnormal gait that you see in patients with foot drop is high step gait. Absolutely correct, Anisul. You are absolutely correct. Let's look at next question. Again, a very important previous year question. A 27-year-old male had sustained a fracture of his right upper limb, which was treated by the doctor with a cast shown in the image. Which fracture has the patient sustained? Can you tell me? Can you tell me what kind of plaster is this, or what position is the plaster given? It looks like as if he is holding a glass, isn't it? Very good, very good. All of you are absolutely correct. RS, Nagma, Sakshi, Joanne, absolutely correct. Maramba, absolutely correct. This is the glass holding position. Very good, guys. Very good. This is the glass holding position, and it is useful for scaphoid fractures. Very good. Now, there are a few other casts that you need to learn. Okay. One is your handshake cast, which is given for 𝗴𝗁𝗃𝗃 fracture. So this is your handshake cast. Remember, look at this picture carefully. Here the thumb is free. 𝗴𝗁𝗃𝗃 fracture, the 𝗴𝗁𝗃𝗃 cast or the handshake cast, the thumb is free. Here the thumb also has a plaster. Okay, so the students generally tend to confuse between the 𝗴𝗁𝗃𝗃 cast and the scaphoid cast. Remember, scaphoid cast, the thumb will be involved inside the plaster. In 𝗴𝗁𝗃𝗃 cast, the thumb would be free. Then cast in glass holding position is obviously scaphoid fracture. Cast in James position, this is the James position, is for boxer's fracture. Cylinder cast, we learned, is for patellar fracture. And patellar tendon bearing cast, the previous year question. This image was asked, isn't it? So patellar tendon bearing cast is basically a below knee cast, but there is a proximal extension like this which covers the patellar tendon. Remember, it is not used for patellar fracture, not used for patellar fracture. It is used for tibia fractures. Please do not confuse, okay? Patellar tendon bearing cast, not for patellar fractures, but for tibia fractures. Understood? Okay. Next question. A 6-year-old child brought to the OPD with difficulty in abduction of shoulder since birth. So it's a congenital anomaly. On examination, he has a deformity of the back as shown in the picture. What is the diagnosis? Quickly tell me the answer. What is the diagnosis? What is the answer? I'll show you here. You can see this is the scapula of the child, which is at a higher level. Here the scapula is at a normal level. So this is normal. This is the affected side. So what you see here is a congenital failure of descent of scapula. What do you call this condition? This is called the Sprengel shoulder. Pankaj Verma, absolutely correct. You have got this correct. This is Sprengel shoulder. You need to know this. This is a previous year question. Okay, Sprengel shoulder. So always, whenever they ask you regarding congenital anomaly, look at the level of the scapula. Here, if the scapula level is high, then it is Sprengel shoulder. So what happens here is that during embryonal development, actually both the scapula will be near the neck, and over a period of time, slowly descends down. Sometimes there is an abnormal bone connection between the cervical spine and the scapula. This will prevent the normal descent. Okay, that is your Sprengel shoulder, and there is a surgery that we can do to cure it. This is called the Green's procedure. Okay, Green's procedure or Green's surgery. That is the surgery that we do for Sprengel shoulder. Understood? Now, there is another congenital anomaly that students always confuse with Sprengel shoulder. I don't know why. Here, the deformities in the neck or a congenital abnormality of the neck characterized by 3 things: a short neck, low hairline, and stiff neck. Come on, tell me, what is the diagnosis fast? What is the diagnosis? Triad of 3 things. Turner is a chromosomal anomaly. This is something different. The congenital anomaly of the neck. This is called 𝗵𝗄𝗄𝗃 syndrome. 𝗵𝗄𝗃 syndrome. Okay. Always remember this. Don't worry if you haven't heard about it. Just read or learn it now. Just remember the picture. This is 𝗵𝗄𝗃 syndrome. These patients have 3 problems. There is a short neck. There is a low hairline, and a stiffness of neck. This occurs because of congenital fusion of the vertebrae. That is all right. Just know the triad. That is all. 𝗵𝗵 syndrome. Okay. Next question. Identify the brace shown in the image. Can you tell me the answer? What is the brace shown here? Quickly tell me the answer. Again, a previous year question. Very, very important. Anisul has got it correct. This is Dennis Brown splint. Okay. Many of you are saying that it is associated with CTV shoes. It is used for CTV, but it is not CTV shoes. It is Dennis Brown splint. Okay. Always remember this. You have two shoes like this, which keeps the foot in abduction, and there is a central bar. So if there is a picture like this, remember this is Dennis Brown splint. See, these are very, very easy marks that you can score for your exam. These are very often repeated questions for FMGE as well as for NEET exam. So please do learn this. Dennis Brown splint is for CTV, and this is the diagram. Okay. There will be two shoes for a child with a central bar. Okay, that is your Dennis Brown splint. And Dennis Brown splint, as already discussed, is used for CTV, also known as club foot. What is this? This is a congenital anomaly where the foot of the child is abnormally bent like this. This is the most common congenital anomaly in India. The most common congenital anomaly in India. And how do you treat it? Treatment is by serial casting. You serially manipulate the foot of the child, and then you put plasters like this. And over a period of time, we can correct it. And the method is called 𝗏𝗏 method. Another MCQ, 𝗏𝗏 method of correction. 𝗏𝗏 method of correction. Okay. The another question they will ask you is, what is the time period when you start the treatment? Will you start it after 3 months, 6 months? No, you have to start the treatment as early as possible. Generally, practically speaking, we start the treatment at 2 weeks of age. When the child is 14 days of age, we'll start treatment for CTV correction. Okay. Again, there is a order in which you correct the deformities in CTV. Okay. What is the order? You can remember it like this. 𝗲𝗵 is the order. Okay. First deformity that you correct is 𝗲𝗵. Then you correct adductus and varus, and the last step you correct equinus. Okay, of which you can remember this, just these two. First deformity to be corrected is 𝗲𝗵, last deformity corrected is equinus. Remember 2 weeks of age and 𝗏𝗏 method. Okay, all these are very, very important questions. CTV invariably asks for exams. Okay. So once you treat CTV, after putting plasters, the deformity will get corrected. But you cannot leave the child because there is a high incidence of recurrence. Okay. So we use two braces or devices to maintain the correction. Till 1 year of age, we keep this splint. This is your Dennis Brown splint. This is your Dennis Brown splint, which we use till 1 year of age. After 1 year, when the child starts to walk, we give CTV shoes. Now there is an MCQ here. Okay. They will ask you which is not a feature of CTV shoes. So you need to know the features of CTV shoes, isn't it? There are 3 features. One, the inner border of the foot of the shoe usually is curved in normal shoes, but it will be straight in CTV. Again, there will be a lateral raise for the sole for CTV shoes, and there will be no heel. So straight inner border or the medial border will be straight. The outer border, that is a lateral border, will be raised, and no heel, absent heel. These are the 3 features of CTV shoes. Okay, no other feature will be there. So this also you need to learn. All right. So we move on to the next question. A 12-year-old boy, known case of hypothyroidism, presents with pain on his left hip. His weight is 70 kg. He is unable to walk, and on examination, hip is externally rotated and adducted. What is the most probable diagnosis? Again, a very, very important clinical opinion. Do we know the answer? Very, very important clinical vignette. Dr. Reckless, absolutely correct. Absolutely correct. Well done. Well done. So this is the classical slip capital femoral epiphysis. Slip capital femoral epiphysis. So let me explain to you what that is. Okay. So I will draw the femur in an adult. So this is the femur in an adult. But in a child, it is not like this. You have something in between at the level of the neck. What is this? This is the growth plate. The growth plate or the physis will be there at the neck. So sometimes what will happen is that there will be weakening of the physis. What happens when the physis weakens? When the child starts to walk, the femoral head will dislocate inferiorly like this. Femoral head should be like this, but it will slip inferiorly like this. This is what is called slip capital femoral epiphysis. Capital means what? Head. Femoral is femur. So basically it means slipping of the femoral head in a child. That is slip capital femoral epiphysis. Okay. So this is an idiopathic condition. This means that we do not know why this happens. Okay. But there are certain risk factors. This is very, very important. Please listen to me here. So risk factors, one is age. Age between 12 to 16 years when the puberty starts. Okay. Then gender. This is usually seen in boys. Then what else? Obesity. Obesity is the most common cause of slip capital femoral epiphysis. Then hypothyroidism. Hypothyroidism. Okay. All these are risk factors of slip. Once slips occurs, there will be severe pain in the hip for the child. The child won't be able to walk. And on examination, the hip will be adducted and externally rotated. Okay. So look at the question. The age 12 years. That is correct for slip, isn't it? Hypothyroidism is there. That is again a risk factor. What about the weight? 70 kg. Imagine a 12-year-old boy with 70 kg weight. Obviously, the child is obese. Okay, obesity is there. And there is pain. All the other features of slip capital femoral epiphysis is there. So even if you don't learn too much about slip, please remember this clinical vignette. Okay. Exactly similar features will be given for your question in your FMG exam. So please learn this clinical vignette. Understood? Okay. Next question. Very, very easy question. Probably the most commonly asked question in the history of NEET as well as FMGE. A 35-year-old female complains of pain and swelling in her right wrist for 3 months. X-ray is given. What is the diagnosis? Quickly tell me the answer. What do you see here? Very good, very good. Sundar, Sakshi, Dr. Reckless, Pankaj Verma, absolutely correct. All of you are absolutely correct. This is the classical giant cell tumor, isn't it? You can see that this is an adult female. And what do you see here? There is a lytic lesion in the distal femur, which is epiphyseal. Epiphyseal. It is mainly involving the epiphysis. It is extending into the metaphysis, but that is all right. If a tumor is in the epiphysis, it is an epiphyseal tumor, irrespective of whether it is extending into the metaphysis. Okay, any tumor in the epiphysis is epiphyseal tumor. Then it is eccentric. Eccentric means what? It is closer to the lateral cortex like this. So it is an eccentric tumor. It is expansile. It is expanding, isn't it? And it has a soap bubble appearance. All these are classical features of giant cell tumor. Giant cell tumor. Okay. Now, one important MCQ that you need to learn is how do you treat giant cell tumors? It is by something called as extended curettage. Extended curettage. Okay. That is a question that could be asked. Extended curettage is treatment for giant cell tumor. Next question. Again, very commonly asked, especially for FMG. Next question. Can you give me the answer? A 10-year-old boy presented with a swelling in the right thigh. X-ray is given below. What is the diagnosis? Sundar, you are absolutely correct. You can safely go and write your exam. No problems. What is the answer to this question? Very good. Pankaj, Anisul, Moramba, Sakshi, absolutely correct. This is your classical osteochondroma, isn't it? You can see that a tumor is arising from the metaphysis. There is a pedicle and there is a swelling at the end. This is a classical feature of osteochondroma. Other features are, you can see that the cortex of the parent bone is continuing with the cortex of the tumor. The medullary cavity of the parent bone is continuing into the tumor. The growth of the tumor is away from the knee joint, away from the joint line. All these are features of your osteochondroma. Remember, this is the most common bone tumor. Most common bone tumor is osteochondroma. There are few important MCQs that you need to know here. One is, what is the malignancy? Malignancy that you see in osteochondroma. What is it? It is chondrosarcoma. Chondrosarcoma. Okay. Don't think that the malignancy that can arise from osteochondroma. Osteochondroma is benign, but it can give rise to a malignancy. It is not osteosarcoma, it is chondrosarcoma. Please remember it. Okay. Another question that can be asked is the most common cause of pain. Most common cause of pain in the case of your osteochondroma is bursitis. These are very commonly asked MCQs. Bursitis because it can press on a bursa and cause inflammation. Okay. Two important MCQs with respect to osteochondroma. There are few more important tumors that are often asked in FMGE. So I'll quickly recap those. Okay. I'll show you the X-rays. You have to quickly tell me the answer. Okay. Can you tell me this? What is the answer here? Can you tell me the tumor here? It is arising from the femur. It is diaphyseal. There is a central radiolucent area with surrounding sclerosis. Can you tell me? You have central lytic area called nidus with surrounding sclerosis. What tumor is this? Very good, Anisul. Pankaj, absolutely correct. This is osteoid osteoma. Osteoid osteoma. Okay. One important feature that is often asked is, it's clinically, it usually presents with pain, which resolves with, which disappears with NSAIDs. Okay, disappears with NSAIDs. That is the classical feature of osteoid osteoma. Moramba, Natma, Pankaj, absolutely correct. All of you are absolutely correct. Next X-ray. Can anyone tell me? Here you will see that there is a large lytic area in the proximal femur. That is not important. What is important is this excessive deformity of the proximal femur. And this deformity looks like the curved stick of a shepherd. What is this? What do you call this? This is called the shepherd crook deformity. Shepherd crook deformity. Very good. RS Anisul Nakma, absolutely correct. Brilliant, brilliant. This is shepherd crook deformity of fibrous dysplasia. Fibrous dysplasia. And you remember that there is a genetic mutation responsible for this, that is GS alpha mutation. And the biopsy finding in fibrous dysplasia is Chinese letter pattern. Chinese letter pattern. Okay. These are the MCQs that you need to learn in fibrous dysplasia. Next, can you tell me what tumor is this? This is a malignant tumor of femur, and it is arising from the distal femur. It is arising from the metaphysis, and it has this characteristic periosteal reaction, which is called the sunburst periosteal reaction. Can you tell me the answer? What is this diagnosis? Brilliant, brilliant. Absolutely correct. This is sunburst of osteosarcoma. Osteosarcoma. Okay. So these are the questions you can expect. Again, what you see here, this is again a metaphyseal tumor. And here there is an elevation of the periosteum with a triangular area underneath. What is this? What do you call this triangle? This is the Codman's triangle. Codman's triangle. And in which condition do you get this? Again, you get this in. Again, you get this in osteosarcoma. Again, you get this in osteosarcoma. Very good, Nagma, RS, Pankaj. Absolutely correct. You are all very good. So, again, remember sunburst, periosteal reaction, and Codman's triangle. Both are characteristic of osteosarcoma. It is the most common malignant tumor of bone, and it is treated by chemotherapy and surgery. It is radio resistant. Okay, remember these points. What is this? Very easy question. Tell me quickly. What tumor is this? There is a tumor in the femur arising from the diaphysis, the classical periosteal reaction called onion peel periosteal reaction. What is this? Very good, very good. All of you are absolutely right. This is the classical 𝗵𝗿liche sarcoma. This is 𝗵𝗿liche sarcoma. There are few important MCQs that are often asked. Remember, when you take biopsy of 𝗵𝗿liche sarcoma, you get round blue cells. Everywhere there will be round blue cells. These cells will be MYC2 positive. This is an MCQ. MYC2 positive, important question in pathology and orthopedics. And there is a genetic mutation involved. Can anyone tell me the genetic mutation involved in 𝗵𝗿liche sarcoma? Genetic mutation in 𝗵𝗿liche sarcoma is translocation 1122. Remember 𝗵𝗿 and 11. Okay, 11 and double of 11. 𝗵𝗿liche sarcoma causes 11 is caused by 1122 translocation. 1122 translocations. Okay. Yeah, Nagma, you are correct. There will be some pseudo rosettes as well, but those are not asked for as MCQs. So I will not be discussing topics which are not very relevant to your exam because there are only 10 days left. No. Nagma, correct. Absolutely correct. This is 1122. Okay. So next we move on to some infections. Very important question here. A 16-year-old male presents with chronic osteomyelitis of humerus. His X-ray is given below. What is the mark structure? Can you tell me? What is the mark structure? You can see that there is a lytic area, which is obviously, because it is chronic osteomyelitis, this is an abscess. And inside the abscess, you see that there is a sclerotic bone, sclerotic piece of bone. In bone, if the bone is sclerotic, it means that it is whiter than the surrounding structure. It is whiter than the surrounding structures. If it is whiter and sclerotic, it means that it is dead. It is dead. So a piece of dead bone inside is, again, brilliant guys. You are absolutely brilliant. All of you are giving the right answer. This is the classical 𝗬𝗃𝗓𝗃. 𝗬𝗃𝗓𝗃 is the piece of dead bone that you see in chronic osteomyelitis. Chronic osteomyelitis is an osteomyelitis that has been going on for more than 2 months, and it is characterized by 4 important things. You need to remember this. Listen carefully. 4 things. One is 𝗬𝗃𝗓𝗃. What is 𝗬𝗃𝗓𝗃? It is a piece of dead bone that is inside the abscess cavity. It is a bone that has been killed by the infection. That is your 𝗬𝗃𝗓𝗃. Okay. Then around the 𝗬𝗃𝗓𝗃, there will be new bone that will be formed. That is called the 𝗵𝗿ᵉ. 𝗵𝗿ᵉ is produced because the pus will irritate the periosteum, and there will be new bone formed. That is your 𝗵𝗿ᵉ. And pus will try to escape from the abscess, isn't it? And it will form a hole in the 𝗵𝗿ᵉ through which it will come out. It is called cloaca. The opening in the 𝗵𝗿ᵉ is cloaca. And sinus is the opening in the skin through which the pus comes out. Okay. Generally, students confuse between sinus and cloaca. What is the difference? Remember, S is for sinus and S is for skin. Okay. Remember, S is for sinus. So it comes from skin, and cloaca is an opening in the 𝗵𝗿ᵉ. So if you look at this clinical picture, you can see this piece of dead bone. What is this? This is the 𝗬𝗃𝗓𝗃. What else do you see? You can see that there are a lot of new bone that has formed. All these new bone formed is your 𝗵𝗿ᵉ. And finally, you can see that there is an opening in the 𝗵𝗿ᵉ through which pus will come out. That is your cloaca. So all these can be seen clinically. X-ray wise also, except sinus, because it is in the skin, it won't be visible on the X-ray. All the other bony changes can be visible. So sequestrum will appear as a dense piece of bone like this. The abscess cavity will be like this. Cloaca, can you see the small opening through which the pus is going to come out? That is your cloaca. And if you see here, because of the infection, there is thickening of the bone. This is all new bone that is formed, which is your involucrum. So all these can be seen on an X-ray, but 99% of the time, if they are asking, the question will be on sequestrum. Okay. So next question. A 15-year-old boy presents with pain of his right leg and occasional fever for the last few weeks. X-ray shows a circumscribed lytic area in the proximal tibial metaphysis with surrounding sclerosis. What is the diagnosis? Tell me the answer. Very good, Pankaj. Legendary Ritvik, absolutely correct. Adi, Anisul, absolutely correct, guys. You are absolutely correct. The answer is Brodie's abscess. Brodie's abscess. Okay. So I am expecting this year a lot of FMG students are going to clear because all of you are brilliant. Okay. From your answering, I know that your preparation has been good. Otherwise, it's not easy to arrive at the answers easily. Okay. So the point to be noted here is this: a circumscribed lytic area in the proximal tibia with surrounding sclerosis. You have to learn this phrase by heart. This is the definition of Brodie's abscess. Okay, you can see here there is a lytic area with surrounding sclerosis. Brodie's abscess is a type of subacute osteomyelitis. And how does this happen? So you have the tibia like this, the physis here. This is the epiphysis. This is the metaphysis. And unfortunately, an infection has occurred in the metaphysis and an abscess is formed. But the body wants to stop the spread of the abscess. So what will it do? It will form new bone around the abscess. So there is sclerotic new bone formed around the abscess. This is your Brodie's abscess. Abscess in the metaphysis with surrounding sclerotic bone. When you take an X-ray, abscess will be radiolucent and the surrounding sclerotic bone will be visible as white line. That is your definition that you read in the Brodie's abscess. Okay, very, very important question. So shall we move on to the next question? A 3-year-old child presents with lethargy and bolex. Her wrist X-ray is shown in the image. What is the diagnosis? Again, very commonly asked question. What is the diagnosis here? Joanne, Ritvik, Nagma, Anisul, absolutely correct. This is the classical presentation of rickets. I'll tell you an easy way. If in an adult, a wrist X-ray with a lytic lesion is kept, the answer would be GCT. If in a child, a wrist X-ray is given, I'm talking about orthopedics, okay. A wrist X-ray is given, probably it is rickets, okay. In an adult, wrist X-ray means GCT. In a child, wrist X-ray means a rickets, okay. This is not foolproof, but always keep this in mind, okay. And read the rest of the question because before jumping into the answers. So always keep this point in mind. So if you look at the X-ray, the classical features of rickets are present here. Okay, all the features are in the end of the bone. This is the metaphysis. You will not be able to recognize that this is the metaphysis. Why? Because this is a very young child and the epiphysis has not ossified till now. Okay, anyway, this area, the end of the bone is different. What are the changes that you see here? First change, if you see, there is this funnel-shaped widening of the metaphysis. This is called splaying. Okay. Then you can see there is a depression in the metaphysis. This is called cupping. And if you look closely, there will be this brush-like ending seen at the ends. This is called fraying. Okay. So splaying, cupping, and fraying of metaphysis. Diagnostic of rickets. So you don't have to look at any other options. This is diagnostic of rickets. Now, rickets again is a very important topic for your exam because you learn this in biochemistry, in pediatrics, as well as in orthopedics. So you need to be thorough with rickets. There are lots of important clinical features. I'll tell you the basic MCQs. Okay. The earliest clinical feature is this craniotabes. The earliest clinical sign is craniotabes, where the skull is very soft, and if you press gently, the skull will go inside. So that is your craniotabes. Okay. Then in the chest, you can have rachitic rosary, specter carinatum, and Harrison sulcus. And in the lower leg, you get bowing of legs. So listen to me, there is an important point here. Bowing of legs will appear only after 1 year of age. Okay, remember this, after 1 year of age. Why? Because the child will start walking only after 1 year of age, isn't it? Before 1 year of age, how can you get the deformity? So this has been asked previously. Okay, so after 1 year only, the bowing of legs will start. So what is this rachitic rosary? It is this finding that you see here. Okay, this is the thickening of the costochondral junctions. And this looks like a rosary. Rosary is prayer bead. Prayer beads. You know the prayer beads, no? Which people used to pray. That this looks like this. That is why we call it rachitic rosary. Remember that rosaries can be seen in two conditions: rickets as well as scurvy. Okay. In rickets, the rosary will be round and painless. In scurvy, it will be sharp and painful. How do you remember this? R is for rickets, R is for round. S is for scurvy, it is sharp. Okay, that is how you differentiate the rosaries. What is Harrison sulcus? It is a depression under the ribs like this. Depression under the ribs. This occurs because of the pull of the diaphragm on the soft bones. Bones become soft because of rickets, and because of continuous pull of the diaphragm, there are grooves under the chest, in the anterior chest wall. That is your Harrison sulcus. In rickets, three kinds of deformities can occur. One is bow legs, other is knock knees, and windswept deformity. Okay. Bow legs, you need to know the definition. It is bilateral 𝗬𝗏𝗃, and this is the most common deformity that you see in rickets. Knock knee is bilateral 𝗬valgum, and windswept deformity is when there is 𝗬varum on one side and 𝗬valgum on the other side. So 𝗬varum plus contralateral 𝗬valgum. That is your windswept deformity. Remember, the most common is bow legs. Next question. Which of the following is a fracture seen in osteoporosis? Let me see how many of you recognize this question. Where I have lifted this question from? I've stolen this question from some paper. Can anyone tell me? Let me see how many of you have prepared well. What is the answer? So this was a question from the recent INICT paper. Okay. So this is a very simple, straightforward question. I think you can also expect a similar question because rickets and osteoporosis are the two favorite questions, areas of questioning for FMGE as well as for NEET exams as well as for INICT. Last time a questions came from scurvy, but this time I don't know. I think they will go back to osteoporosis and rickets. Very good. 𝗏𝗃 Nagma, absolutely correct. This is a fracture of the vertebra, isn't it? What is osteoporosis? It is a condition seen in elderly, postmenopausal women, isn't it? What is the feature? There is a reduction in the bone mineral density. And bone mineral density reduces, the bone becomes weak, and the maximum problems will be in the spine. Okay. Osteoporosis will affect maximally in the spine. Then it will affect the hip, then it will affect the metaphyseal areas of the long bones, especially the wrist. Okay, so you can get fractures of the vertebra very easily. Other fractures, shaft of humerus, tibia, and calcaneum are all traumatic fractures that occurs after a fall. fracture of the vertebra is specifically associated with osteoporosis. Okay. So these are the fractures that you can see: intertrochanteric fracture of the hip, fracture neck of femur, Colles fracture, and in the spine, the osteoporotic fracture that we see is your wedge compression fracture. Okay, remember this wedge compression fracture. What is wedge compression fracture? Normally, our vertebra is like this, a beautiful rectangle. And what has happened here? Here, the vertebra has become squished, isn't it? It has become compressed anteriorly like this because of a fall or something. And here, the anterior height is very much reduced when compared to the posterior height. This is called the wedge compression fracture. This is a relatively minor fracture. We see this all the time after an elderly patient falls down, and we treat them with this brace. What brace is this? What brace is this? This is the Taylor's brace. Taylor's brace. Okay. Now, what is the investigation of choice in osteoporosis? Someone I think already mentioned. 𝗏𝗏 has answered even before I have asked the question. The investigation of choice is DEXA scan. DEXA scan, which is dual energy X-ray absorptiometry. DEXA scan. And what is the treatment of choice? Treatment of choice, can anyone tell me? Treatment of choice, which drug or which group of drugs do we give for osteoporosis? Again, an important MCQ. Pankaj, absolutely brilliant, absolutely correct. This is bisphosphonates, bisphosphonates, okay? Bisphosphonates. So these are the important MCQs from osteoporosis. Next question. So let me see how many of you get this correct. Sangeeta gave birth to her first child 2 days back. She was informed by the doctor that the delivery was difficult as the shoulder of the child was stuck in the birth canal. Probably this indicates shoulder dystocia. Now she noticed that the baby was not moving the right upper limb. And the deformity is shown in the image. What is the diagnosis? Very good. Joanne, 𝗏𝗏, Pankaj, Anisul, Nagma, all of you are absolutely correct. The answer is 𝗶𝗃. What deformity do you see here? You can see that the shoulder is internally rotated and adducted. The forearm is extended. The forearm is pronated. And the wrist is flexed. This is the classical. Yes, Pankaj, correct. This is the policeman or the porter's step deformity. Classically seen in 𝗶𝗃. What is 𝗶𝗃? It is an upper brachial plexus palsy. See, brachial plexus are made up of 5 roots, isn't it? C5, C6, C7, C8, and T1. When the upper 3 roots are involved, we call it 𝗶𝗃. And the lower 2 roots are involved, we call it 𝗏𝗃's palsy. How do you treat 𝗶𝗃? Using the splint. It can be asked as a spotter. Sharina, Anisul, Pankaj, absolutely correct. This is aeroplane splint. Aeroplane splint. Good, guys. Very good. Very good. Well done. Okay. Now tell me what this is. This is not so easy. Tell me. What do you see here? There is complete claw hand. And here you have Horner's syndrome. Where do you see the combination of complete claw hand and Horner's syndrome? Can anyone tell me? We already discussed it just now. Lower brachial plexus palsy. Horner's syndrome with complete claw hand is seen in which condition? It is seen in 𝗏𝗃's palsy. Okay, 𝗏𝗃's palsy. Just remember this. 𝗏𝗃's palsy is a lower brachial plexus palsy which is characterized by complete claw hand and Horner's syndrome. Okay. Next question. Very easy question. A 25-year-old male presents with weakness of grip after injury. Test shown in the image is positive. What nerve is injured? I know that all of you know the answer. I want all of you to type in the answer because this will build up the confidence when you go for your exam. Okay. Many a time students get stuck between 140 and 150 marks. This usually happens because of careless mistakes, and careless mistakes occurs because they are not confident enough in answering questions. Okay, so please practice this. All of you type in the answers. Sharina, Anisul, Nakmal, Ritvik, absolutely correct. What you see here is your pen test, which is positive in median nerve. Okay, pen test, where what you do is that you keep the pen on top of the finger like this. Ask the patient to lift the thumb, that is, abduct the thumb and touch the tip of the pen. So this is your pen test, and here we are testing the thumb abduction, which is brought about by the abductor pollicis brevis, which is supplied by your median nerve. Okay, now let's quickly revise median nerve. See, median nerve can be injured in two ways. Either it can be injured in the lower level, at the level of the wrist. If that is the case, then the thenar muscles are paralyzed. The abductor pollicis brevis, opponent's pollicis, and flexor pollicis brevis are paralyzed. And because of this, the thumb will externally rotate it and be like this. This is what is called as ape thumb deformity. And the test we do is for this is pen test. And the splint that we use for correcting ape thumb deformity is the opponent splint. Okay, 3 MCQs here. Now, what happens if there is a high level of injury here? Obviously, the thenar muscles will be paralyzed. So you get ape thumb and all, but along with that, the flexor 𝗬𝗏𝗯 superficialis and the flexor 𝗬𝗏𝗯 profundus lateral half will be paralyzed. So the patient will have difficulty flexing the index finger. So if you ask the patient to make a grasp like this, the index finger will be protruding like this. This is what we call as the pointing index. Okay. Sometimes the patient won't be able to flex the middle finger also. If that is the case, then you call it a benediction sign. Okay. So this is pointing index and this is benediction sign. And sometimes if you ask the patient to grasp both the hands together, again, the index finger will be upright like this. This is called the Ochsner clasp sign. You don't have to go into the details. Just remember the names. Pointing index, benediction sign, or median. Next question. A 45-year-old female who is a known case of hypothyroidism presents with paresthesia of lateral 3 fingers of right hand for last 6 months. On examination, Durkin test is positive. What is the diagnosis? Very good. Brilliant. Brilliant, Sharina. Absolutely correct. The answer is carpal tunnel syndrome. Remember the name of the test. Okay, Durkin test is for carpal tunnel syndrome. What is carpal tunnel syndrome? It is a condition where there is compression of the median nerve under the flexor retinaculum. You have the flexor retinaculum here, underneath which the median nerve passes. There could be a compression of the median nerve there, resulting in paresthesias. And it is usually seen in women between the age of 30 to 50 years. And it will be very symptomatic. The patient won't be able to do anything. When they talk on the phone, they will have paresthesias of the hand. They will come and tell you that, oh, doctor, I cannot sleep at night because of paresthesias. I wake up 5-6 times at the morning and I shake my hand like this, or I rub my hands together. This is the classical carpal tunnel syndrome. And when you hear this, you have to confirm the diagnosis by doing certain tests. The most common test that we do is Phalen's test. We all know this, isn't it? Here we ask the patient to keep the wrist like this. Post palmar flexion for a period of 60 seconds to see if there is reproduction of symptoms. Or you can use the reverse Phalen's test, where you ask the patient to hold like this, namaste like this, for a period of 60 seconds. That is also enough. But if you are asked which is the most significant or the best clinical test for carpal tunnel syndrome, the answer is Durkin's test. Best clinical test is Durkin test, which is a direct compression test of the carpal tunnel, where you are pressing the carpal tunnel with your thumbs and holding it like that for a period of 30 seconds to see if there is reproduction of symptoms. Okay, that is your Durkin's test. So important 3 tests. Now, another common nerve compression that is nowadays very commonly asked during various entrances is your thoracic outlet syndrome. You don't have to go into the details. Just remember that it is a triangular area in the neck bounded by the scalenus anterior the first rib, and the clavicle. What is important is what is inside this triangular space. You get the brachial plexus and the subclavian vessels. And if there is a compression of these structures, there will be severe paresthesias of the arm. Okay. In carpal syndrome, there is paresthesias of the fingers. Here, there is paresthesias of one full upper limb. Okay. That is your thoracic outlet syndrome. The important MCQ is this. The test for thoracic outlet syndrome, please remember this. This is a very, very important MCQ. AdSense test. AdSense test is the test for thoracic outlet syndrome. Very simple test. You stand behind the patient, you palpate the radial artery and ask the patient to turn to the same side of the limb. And when the patient turns, what happens is that if there is thoracic outlet syndrome, the subclavian vessels will get compressed, and what will happen? The radial pulse will vanish, will disappear. And when the patient turns back, it will reappear. This is your AdSense test. Again, if you don't want to remember the whole thing, it's okay. Remember at least the name of the test. AdSense test is for thoracic outlet syndrome. Next question, very easy question. Identify the condition for which the spleen shown in the image is used for. Can you tell me? Very easy question, isn't it? Absolutely correct. All of you are correct. This is the cock-cup spleen. Cock-cup spleen for radial nerve injury. Next question. A 20-year-old man presents with weakness of his grip. On examination, the following test is positive. Which nerve is injured? Think and answer which nerve. What test is this? Here the examiner is and the patient is holding a card between the fingers and the examiner is pulling it in the opposite direction. Here we are testing for the finger adduction strength, isn't it? And finger adduction is brought about by your palmar interosseous, which is supplied by which nerve? Yes, very good, very good. Ritwik, Anisul, Sharina, absolutely correct. This is the card test for your ulnar nerve injury. Again, ulnar nerve is a very, very important topic. So, when the ulnar nerve is injured, all the intrinsic muscles of your hand, most of them are paralyzed. So, the third and fourth lumbricals are paralyzed, which will cause the claw hand deformity. Then the adductor pollicis, which is the only thenar muscle supplied by the ulnar nerve, will be paralyzed. So, book test and Froment sign will be positive. Palmar interosseous, which are your finger adductors, are paralyzed. So, you get card test and Wartenberg sign positive. All the dorsal interosseous are paralyzed. So, you get the 𝗖𝗵 test positive. Okay. Very, very important table. I want all of you to learn this table by heart. Okay. The different muscles paralyzed and the tests that are positive. This is your claw hand. Claw hand. This is a previous year question. Because only the ring and the little finger are involved, this is a partial claw hand. Okay. And this occurs because of the paralysis of the lumbricals, and because of which you get hyperextension at the metacarpophalangeal joints and the flexion of the IP joints like this. This is your claw hand deformity. And the treatment of claw hand is using the splint, which is your knuckle bender splint. Knuckle bender splint. Okay. Joanne, Nagma, absolutely correct. Anisul, correct. Very good. Next test is your book test. What is this? You ask the patient to hold a book between the thumb and the hand, and the examiner will pull it in the opposite direction. And the patient's hand, from the patient hand, it will slip away because of the paralysis of the adductor pollicis. This is your book test. Okay. This is a positive book test where the book is slipping away. But sometimes what happens is that the patient will subconsciously trick the test by flexing the IP joint and holding on to the thumb like this. And this is what is called as the Froment sign. Absolutely correct. Sharina, absolutely correct. This is the Froment sign. Froment sign. Okay. This is the Froment sign. What test is this? This is the Wartenberg sign. Wartenberg sign. Here you can see that the patient is not able to adduct the little finger. He is not able to adduct the little finger, and the little finger is abducted like this. Again, this occurs because of the paralysis of the palmar intrusion. Okay, this is your Wartenberg sign, and you have the 𝗲𝗏 sign, which is the inability to move the middle finger to and fro. Why are we choosing middle finger? Because remember, middle finger only has dorsal intrusion, no palmar intrusion. So both these movements are brought about by your dorsal intrusion. In the ulnar nerve injury, the patient won't be able to move the middle finger towards. Okay, so that is your 𝗲𝗏 test. Even if you don't remember all these tests, how they do it, it is okay, but remember the names at least. I have given you the table, learn the table by heart. Okay. Next. A 24-year-old male presents with knee pain and difficulty in walking after injuring himself by playing football. On examination, the Lachman test is positive. Which structure could have been injured? What is the answer? Let's look at the answers. Very good. Ritvik, Anisul, Sherina, absolutely correct. Where are the others gone? Yeah, Pankaj. Pankaj has come back. He is not answering for some time. Now he has started answering. Come on, everyone should answer. Okay. So, this is a clear-cut case of ACL injury. This is the classical case of ACL injury. Why? The Lachman test is positive in ACL injury. Okay. So, Lachman test is a very simple test. You ask the patient to lie down, flex the knee to 30 degrees. You flex the knee to 30 degrees and gently see if the tibia is subluxing anteriorly. If the tibia is subluxing anteriorly, this means that the ACL, which is connecting the femur and the tibia, is broken. That is your Lachman test. Again, it's not necessary that you learn the test, learn the names. Okay. So, this is again a very important table which gives you the common test for various ligament injuries of the knee. ACL injuries, you can test it with an anterior drawer test, Lachman test, bounce home test, and pivot shift test. PCL, we have 3 tests: 𝗬cie drawer, 𝗏𝗏𝗏 and quadriceps active test. MCL, it is valgus stress test and LCL varus stress test. Meniscus, we have McMurray, Apley grinding test, and Apley distraction test. So before your exam, just by heart, few tables I have given you, so you can, if you learn them, then maybe you can get 1 or 2 questions right from those. Okay, very, very important tables. So, moving on, next question. Very important clinical vignette. A 50-year-old woman who is on long-term steroids for 𝗵𝗵𝗃𝗃 vulgaris presented with pain of the left hip. X-ray shows a deformed femoral head. What is the diagnosis? Come on, all of you answer the question. What is the answer? Very good, very good. Evangeline, Pankaj, absolutely correct. This is avascular necrosis of femoral head. Sundar, Nagma, all of you are absolutely correct. This is avascular necrosis of femoral head. Remember the key words here, okay? Long-term steroids and hip pain means it is avascular necrosis. Okay, steroids plus hip pain is avascular necrosis of femoral head. What is this avascular necrosis? So, this is your femoral head and you have blood supply coming to the femoral head. Due to some idiopathic causes, idiopathic means unknown causes, there is complete cutoff of the blood supply. So when there is complete cutoff of the blood supply to the femoral head, what will happen? The femoral head will become necrotic or dead. This is what we call as avascular necrosis of femoral head. And because of the necrosis, the bone will become very soft and it will collapse like this. When the patient walks, it will collapse like this, and this will cause pain. You can see this X-ray where the femoral is completely collapsed because of necrosis. This is the classical avascular necrosis. I told you that it is idiopathic. Even though it is idiopathic, there is an important risk factor. And the only risk factor you need to learn is steroid intake. Okay, steroid intake. Maybe the patient is taking steroids for treatment of a neurological condition, or for a skin disease, or for a nephrotic syndrome, or some other inflammatory disorder, SLE. There are lots of conditions for which patients take steroids for a long time. And if they take for a long time, there is a chance that there can be avascular necrosis. Okay. So this is a very, very important MCQ and clinical view. Next question. Which test is used for the school screening of scoliosis? Can you tell me the answer? So Mukherjee is saying, asking me to share the PDF. Definitely after the class, I'll share with the PDF, the PDF with you. Okay. Sherina is saying that there is crescent sign. Yes, very good. Just one more point. I forgot to mention, in an X-ray, you can see something called as a crescent sign. Okay, crescent sign. Sherina, thanks for reminding me. Crescent sign can be seen on an X-ray. Can remember, if you can remember this, well and good. Okay, what about this question? What is the answer? Anisul, Sherina, absolutely correct. This is Adams forward bending test. That is the answer. Okay. For scoliosis, we use Adams forward bending test. What is scoliosis? Scoliosis is a lateral bending of the spine. Some of you have already mentioned 𝗏𝗃 and all for Sprengel shoulder. This is more accurate for 𝗏𝗃. Okay, lateral bending of spine. Lateral bending of spine is your scoliosis. Why do you want to school screen? See, the most common cause of scoliosis is adolescent idiopathic scoliosis. This is seen in young females between 10 to 16 years. These children, girls will develop this scoliosis, and we have to identify it early so that we can prevent the progression of the disease. In Western countries, what they do is that they screen all school children between 10 and 16 years using the Adams forward bending test. Okay, I'll describe what Adams forward bending test is in a bit. Where do you use Schober test first? It is used in ankylosing spondylosis. Okay, ankylosing spondylosis. Patrick test is for sacroiliitis, and Thomas test is for flexion deformity of hip. This is all MCQs. Okay. Thomas test and Schober test are important MCQs for your FMGE exam. So what is this Adams forward bending test? What you do is that simply you stand behind the child and you ask the patient to bend forwards like this, and you see that in a normal spine, it will be absolutely straight. If it is scoliosis, then the deformity will become very clear like this. And on one side, there will be an elevation like this. This is called the rib hump. The rib hump. In school screening, they use the Adams forward bending test. And if there is a rib hump, they measure the rib hump using something known as a scoliometer. And if it is more than 7 degrees, they refer the child to a spine surgeon. That is all. That is your school screening of scoliosis. Again, another very important point in scoliosis is how you treat it. You usually treat it with braces. There are 3 important braces that you need to know. One is your Milwaukee brace, then you have your Boston brace, and the Charleston bending brace. Of which the most important, the previous year question is your Milwaukee brace. How do you identify the Milwaukee brace? It is a brace that starts from the neck. So please listen to me here. Milwaukee brace starts from the neck and reaches till the sacral level. Okay. No other brace will reach till the neck. If the brace is till the neck, it is Milwaukee brace. Okay. It is used for a high level of scoliosis. If the scoliosis is at a lower level, you can use a Boston brace, which starts at the thorax and ends at the sacrum. And Charleston brace is made of soft plastic, which the child can wear during sleeping. Okay, most important is Milwaukee brace. You need to learn to identify this splint from an image. Next question. A 45-year-old lady complains of back pain radiating to her buttock for last 1 year. On examination, there is a palpable step in the lower lumbar spine, and her X-ray is given here. What is the diagnosis? Very, very important, very often asked question for FMGE. What is the diagnosis here? What do you see here? You can see one vertebra here. And what has happened to the other vertebra? Just subluxed on top of the other, isn't it? Subluxation of one vertebra on top of the other is what we call as, what is this? Joanne, brilliant answer. That is absolutely correct. This is spondylolisthesis. The subluxation of one vertebra over the other is called spondylolisthesis. Spondylolisthesis. Okay, it's not slip disc. It is spondylolisthesis. Okay, what is spondylolisthesis? So please listen to me carefully. This is something that I want you to all listen to very carefully here. So let's look at this diagram. So this is, let's say this is L1, L2 and L3 vertebra, and this is the superior articulating process. This is the inferior articulating process. These articulating processes will join together with the adjacent vertebra to form something called as the facet joint. Facet joint. Okay. Throughout the vertebra, you will have facet joints. Now, if you look here, the area between the facet joints has a name. The area between the facet joints is called pars interarticularis. Pars interarticularis. Okay. Pars interarticularis is actually a link between adjacent vertebrae. Sometimes what happens is that there is a break in the pars interarticularis. Okay, a break in pars interarticularis, and this is what we call as spondylolysis. Spondylolysis. Okay, break in pars interarticularis is spondylolysis. Because of spondylolysis, the vertebrae has become unstable. So the upper vertebrae can slip or dislocate anteriorly when compared to the inferior vertebrae. Just like we saw in this X-ray. Isn't it just like this X-ray? The vertebrae can slip on top of the other, and the subluxation is what is called spondylolisthesis. Spondylolisthesis. Understood? That is the concept. Now, there are two X-ray findings that you need to learn in spondylolisthesis. First of all, the X-ray that was shown there in the question, the slippage, you can see one vertebrae has slipped on top of the inferior vertebra. The other is this. You can see that the lower part of the vertebra in the AP view looks like a upside down hat. This is what we call as the inverted Napoleon hat sign. Inverted Napoleon hat sign. Two MCQs. Okay, subluxed vertebra can be seen on an X-ray, and inverted Napoleon's hat sign on anteroposterior view of the X-ray. Okay. Next question. Which is the most dangerous type of odontoid fracture according to the Anderson D'Alonso classification? Can you tell me the answer? Most dangerous type of odontoid fracture. What is odontoid? Odontoid is the dense process of C2. Very good. Sakshi, Joanne, absolutely correct. Brilliant answer. This is type 2. Okay, this is type 2. Very, very, very important point. Okay. So, even if you don't remember the name of the classification, it is all right. Just remember that the odontoid process can be fractured in 3 areas. Okay. One is at the tip like this. Then at the base like this. And third, through the body like this. Okay. What is the problem here? So, if you draw the dense process like this, there is a lot of blood supply coming till here. There is also blood supply coming till here. But this area, which is the waist of the odontoid, does not have much blood supply. And this area is what we call as the watershed zone. Watershed zone. Watershed zone, remember, is the area where the vascularity is not that much. Okay, this is because it comes in between two areas of blood supply. And type 2, as you see here, is a fracture occurring in the watershed zone, because of which there is a high chance of non-union. And if non-union of the odontoid process occurs, what happens? There is a high chance of cervical spinal cord injury, and the patient can develop quadriplegia. That is a disaster, isn't it? So we are always scared when we see a type 2 odontoid fracture, and we always fix it with a screw. Okay? Even if you don't learn all these things, just remember the answer to this MCQ, which is, this has been asked multiple times in NEET. So this time they can probably ask you this. Okay. So type 2 is the most dangerous type of odontoid fracture. Can you identify the brace shown in the image? We have already discussed this. This is a previous year question. What is the brace shown here? Very good. Anisul, Pankaj, absolutely correct. This is the Taylor's brace which we use for wedge compression fractures. Isn't it? We have already discussed this. We use this for wedge compression fractures of vertebra. Okay, usually associated with osteoporosis. I'll quickly give you some important splints. This is the shoulder abduction splint which we use for deltoid palsy. Deltoid palsy is seen in which condition? In axillary nerve injury. Aeroplane splint is for Erb's palsy. Knuckle bender splint for ulnar nerve injury. Opponent splint is for median nerve. Cock-up splint is for wrist drop deformity. We already discussed this. Wrist drop for radial nerve. Foot drop splint is for common peroneal nerve. Philadelphia collar is for neck injuries or neck fractures. And this is very, very important. 𝗵𝗵 harness. Can you tell me which condition we use 𝗵𝗵 harness? 𝗵𝗵 harness. Previous year question. Spotter for you. 𝗵𝗵 harness. Which condition do we use 𝗵𝗵 harness? Can you tell me the answer? Quickly tell me. It is used for Anisul, absolutely correct. Brilliant answer. Anisul, correct. This is for dysplasia of hip. Okay. For developmental dysplasia of hip. Okay. Nagma, absolutely correct. Evangeline, brilliant answer. This is for developmental dysplasia of hip for DDH. Okay. So you don't have to go into the details. Just remember this picture. Okay. You can see that a lot of harnesses or ropes or ties are used to keep the hip of the child in abduction like this. This is for hip developmental dysplasia of the hip. Okay, remember this picture, please. Okay. Next question. Again, a favorite topic among our examiners. A 30-year-old male presents with back pain for 3 years. He has occasional episodes of red eye. Chest expansion is reduced. X-ray is given. What is the diagnosis? Come on, all of you know the answer. Quickly tell me what is the answer here. You cannot go into the exam without knowing this. Very, very, very often asked topic. Brilliant, brilliant. Everyone should answer this. Nagma, Joanne, Sakshi, Pankaj, Reckless Doctor, Evangeline, absolutely correct. This is the classical ankylosing spondylosis. And what do you see here? On the X-ray, we see the bamboo spine, isn't it? Bamboo spine. And why do you get red eye? Can anyone tell me? Why is the patient getting red eye? Others we know. Why is the patient getting red eye? Red eye is because of which condition? It's because of uveitis. Uveitis. Okay. Which is the most common extraskeletal manifestation of ankylosing spondylosis. Ankylosing spondylosis is a systemic disorder. It can affect other organs, especially the eye, where there will be uveitis. So ankylosing spondylitis, I'll just briefly discuss in detail. It is an inflammatory condition affecting primarily the spine and the adjacent joints. There will be inflammation and ankylosis or fusing together of the vertebrae, the costovertebral junctions, the sacroiliac joints, and all the adjacent joints. Even the hip joints can also be involved. And classically, it is seen in males and usually between the age of 15 to 25 years. HLA-B27 positivity is seen in up to 90% of the cases. The most common joint involved is the sacroiliac joint. And remember, it is a type of erosive arthritis. Erosive arthritis. Now, what will be the clinical features? Usually, a 16, 17-year-old young boy will come and he will tell you that I have back pain. When I am carrying my school bag, I am in 12th standard now. I cannot carry my school bag. There are lots of books in it, but I cannot carry it because of back pain. And there is stiffness. The back pain is so bad that when I wake up in the morning, I don't feel like going to the school. There will be morning stiffness. Then the later stage, what will happen is that they will have this kyphotic deformity like this. Sometimes it will be so severe that the spine will be like this, which is called the question mark posture. then the chest expansion will be reduced. There will be enthesitis, especially in the Achilles tendon, and uveitis. Okay, this is a classical presentation of 𝗙𝗵𝗃 and the test that we use to identify the back stiffness is modified Schober test. I am not going to the details, just remember the name modified Schober test, or simply the Schober test is for identifying spine stiffness in 𝗙𝗵𝗃. What will be the X-ray findings? The earliest change would be a narrowing of sacroiliac joint, but it is very difficult to pick up on an X-ray. Then there will be formation of osteophytes that link the adjacent vertebrae together. This is what we call as syndesmophytes. Then sometimes there will be calcification or sclerosis of the edges of the vertebrae, which is called as shiny corner sign. Then you have the classical features in long-standing disease, where there is fusion of all the vertebrae together, resulting in this kind of appearance, which looks like a shaft of bamboo. This is your bamboo spine. Then sometimes there will be sclerosis of the and calcification of the supraspinatus ligaments, leading to the dagger sign. Then sometimes there will be calcification of the central as well as the lateral ligament, resulting in the trolley track sign. So all these are your classical X-ray findings of ankylosing spondylosis. Okay. Next question. A 55-year-old lady presented to the OPD with polyarthralgia for 10 years. She has deformities of the hands now for 2 years. The image is there. What is the diagnosis? Tell me the answer. What is the answer? Yes. Reckless dog, Sharina, Joanne, RS, absolutely correct. This is the classical rheumatoid arthritis, isn't it? What do you see in the X-ray? Sorry. You see here, you can see that all the fingers are deviated medially, isn't it? Or towards the ulna. This is what we call as the ulnar drift of the metacarpophalangeal joints. What else do you see? The thumbs are in the shape of an Z. This is the Z deformity of thumb. And all these features are classical of rheumatoid arthritis. The hand changes in rheumatoid arthritis are very important. Several questions come from this. If you see, the first and the earliest change that you will see will be ulnar drift of the metacarpophalangeal joints. Then there will be swan neck deformity. What is this? Very, very important MCQ. In swan neck deformity, the finger will be abnormal. What will be the abnormality? There will be an hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. That is your swan neck deformity. The reverse of swan neck would be a boutonniere deformity, where there will be flexion of the proximal interphalangeal joint and extension of the DIP like this. This is your boutonniere deformity. Then there can be hitchhiker's thumb, where the thumb of the patient would be like this. Hitchhiker is someone who is asking for a lift leg. So the thumb of the patient will be like this, extended. That is why you call it a hitchhiker's thumb. Then you can have a Z-like deformity of the thumb. That is your Z deformity. So these are the 5 important hand changes of rheumatoid arthritis. So these are important spotters for your exam. Next question. Which of the following condition can cause painful arc syndrome? Can you tell me the answer? Again, a previous year question. Give me the answer. Absolutely correct, Anusul. Absolutely correct. You are, what is the answer? Yeah, B. Supraspinatus tendinitis. Sharina, Evangeline, Reckless Doctor, all of you are absolutely correct. The answer is supraspinatus tendinitis. Okay. What is this painful arc syndrome? This is a very interesting condition. Okay. So the patient will come and tell you, sir, that there is some weird problem with me. When I am lifting my arm like this, there is no problem. But between 60 to 120 degrees, if I lift the arm, there will be severe pain. But if I try to lift it above 120 degrees, no pain. So just the mid abduction, that is 60 to 120 degrees, is painful. Why does this occur? This occurs because of the greater tuberosity. I'll tell you why. See, this is a simplified diagram of our shoulder. You have the humeral head here, the greater tuberosity. This is the glenoid. This is the acromion. And under the acromion, that is between the acromion and the humeral head, we have two things. You have the supraspinatus tendon and the subacromial bursa. Okay. So what will happen here? So when you are abducting the shoulder, and when you abduct it, the greater tuberosity will go under the acromion like this, isn't it? The greater tuberosity will go under the acromion, and when this happens, it will compress the supraspinatus tendon as well as the subacromial bursa. You can see here, isn't it? This happens in all of us, but we don't have pain. Why? Because our supraspinatus tendon and the subacromial bursa is normal. If both of them are normal, no pain occurs. Okay. But if there is any disease in these structures, if there is an inflammation of the subacromial bursa, what we call as the subacromial bursitis, or if there is an inflammation or tear of the supraspinatus tendon, or if there is calcium deposition on the supraspinatus tendon called calcific tendinitis, if any of these things are there, when the greater tuberosity goes under the acromion, it will compress the inflamed tissue and there will be pain. That is why you get your painful arch syndrome. And here the answer is supraspinatus tendinitis. Understood? Next question. A 40-year-old man presented to the emergency department with severe pain of the right ankle. He gives history of attending a marriage function in which he had consumed chicken and beer. Aspiration of the ankle joint shows negatively birefringent crystals. What is the diagnosis? Again, a very, very important question, very often asked. What is the diagnosis here? Brilliant, brilliant. All of you are absolutely correct. This is the classical presentation of gout, isn't it? For those who haven't understood, I'll tell you. So here, the one important point is that there is crystals that are deposited inside the joint. This means that our condition is a crystal arthropathy. What does that mean? It means that it is a condition where there is abnormal deposition of crystals into the joint, causing destruction of the joint. And there are two crystals that can get deposited. One is your monosodium urate or calcium pyrophosphate dihydrate. So when MSU is deposited, you call it gout. When CPPD is deposited, you call it pseudo gout. So it's not septic arthritis or osteoarthritis gout or pseudo gout. So how do you differentiate? First of all, by the symptoms. Gout usually occurs in middle-aged men, 40 to 50, 60-year-old males. In 60-year-old females or in elderly females above the age of 60, we see pseudo gout. Okay. The most common joint involved in gout is the first metatarsophalangeal joint, but the ankle joint can also be involved in gout. In pseudo gout, it is usually the large joints, especially the knee joint, that is involved. Then what is the crystal that is deposited? There will be monosodium urate deposition in gout, while CPPD crystals or calcium pyrophosphate dihydrate is deposited in pseudo gout. Now, how do you differentiate these two crystals? By arthrocentesis. What is arthrocentesis? Joint aspiration. You put a needle into the joint and you aspirate the fluid inside, and you look it into the fluid under the microscope. And if there is monosodium urate crystals, you see needle-shaped negatively birefringent crystals. If that is the case, it is gout. If you see rhomboid-shaped positively birefringent crystals, it will be pseudo gout. How can you remember it? You can remember it like this: PPPP. So this is calcium pyrophosphate dihydrate. That is CPPD crystals. P is for positively birefringent. R is for rhomboid shape. You can make P into an R, and P is again is for pseudo gout. And Na is sodium, isn't it? So monosodium urate. N is for needle shape and negatively birefringent. So you can just remember like this so that you will not be confused between both these crystals. Okay. Remember, monosodium urate is for gout and your pyrophosphate crystal is for pseudo gout. So let's look at our question. This is a middle-aged man and there is pain in the ankle. There is consumption of chicken and alcohol. Meat and alcohol is a trigger for gout, isn't it? And you see negatively birefringent crystals. All these are classical features of gout, isn't it? So this is your classical gout presenting to you. Next question. So which bursa is inflamed in clergyman's knee? Bursitis again is a very, very important topic asked in association with anatomy as well as orthopedics. Okay. Can you tell me? Joanne, Preetham, where were you, man? Preetham, this is the first question you are answering, no? This is the last question, and Dr. Preetham is answering for the first time. Anyway, there I durust aaye, koi problem nahi. Thanks for answering, man. Yeah, all of you are absolutely correct. This is infrapatellar bursitis, the classical infrapatellar bursitis. This is a table that you need to learn for your exam. Housemate's knee is for prepatellar bursitis, clergyman's knee, infrapatellar bursitis, student's elbow involves oedicrenone bursa, Haglund deformity, retrocalcaneal bursitis, and Weaver's bottom is ischial bursitis. And you can learn this table for your exam. Okay. So those were our 30 questions. So I think I have covered almost all important topics. So these topics and the adjacent questions would definitely be asked for your exam. So we have few minutes left. So if you have any doubts that you have regarding any of the questions or even otherwise, you have few minutes to clear those doubts. Can you tell me? So Pankaj is asking where there will be an absent clavicular bone, isn't it? We have something called cleidocranial dysostosis. This is an autosomal dominant condition where there is partial or complete absence of your clavicles. So these patients would be able to bring the shoulders anteriorly and touch the shoulders in front. That is your cleidocranial dysostosis. Gunstock and cubitus valgus. Okay, so Gunstock cubitus varus. Okay, Gunstock cubitus varus, where this is the elbow and this is the forearm. The forearm will be directed like this. If this is the midline, the forearm will go towards the midline. This is cubitus varus. Okay. If the forearm is directed towards the opposite side, so this is the arm, this is the elbow joint, and if it is directed away from the midline like this, this is the midline, and if it is away from the midline, it is cubitus valgus. This is cubitus valgus. Okay, just give me a second. Gunstock is always cubitus varus. It is seen in malunion of supracondylar fracture of humerus. Okay. What else? Elbow dislocation versus pulled elbow. So in elbow dislocation, the humero-ulnar joint is dislocated. So in the lateral view, you have the humerus and you have the ulna. So when this joint is dislocated, you call it what? This is elbow dislocation. Okay. In your pulled elbow, this kind of major dislocation doesn't happen. Okay. So what happens is that you have the radius nearby, isn't it? You have the radius nearby. So the radius will articulate with the capitulum, and this radius will mildly subluxate inferiorly like this. That simple small subluxation is what we call as pulled elbow. Pulled elbow will occur only in a child. So pulled elbow occurs in a child. Okay. And this is a minor injury. There is no major dislocations or displacement. X-ray will be normal. Only thing is that the child will be keeping the hand pronated like this. The treatment is by supinating the forearm. If you supinate the forearm, the child will stop crying. That is the treatment. Okay. What else? Do you have any other doubts? How to know posterior medial lateral subluxation for elbow dislocation? I don't think those kinds of questions won't be asked. Lateral, those kinds of dislocations are very rare. That won't be asked. Okay. So it is possible to identify on an X-ray. You don't have to waste time on all those. The only question they are going to ask is which is the most common type of elbow dislocation. The answer is posterior dislocation. Okay, the most common type of elbow dislocation is posterior dislocation. Fracture healing stages. The stage 1 is hematoma formation. The stage of hematoma formation. Stage 2 is formation of granulation tissue. Granulation tissue. Stage 3 is stage of callus formation. 4 is consolidation. Consolidation. And 5th stage is remodeling. Stage of remodeling. They will not ask you the stages. They will ask you which is the first stage. You know which is the first stage, this hematoma formation. They will ask you which is the last stage, which is remodeling. They will ask you which is the longest stage, which is again remodeling. Okay. All right then. I think most of the doubts are also clear. So I'll just tell you all the best. I think 10 more days, work hard. Many of the students are asking me if the exam is going to be postponed. Don't think about all those things. Okay. So last week, everyone was messaging, sir, I have 2 years internship. What will I do? I was like, man, first you study for your exam. When they will make an announcement regarding that, we'll think about it. So once that issue is solved, next issue is this. Everyone is thinking about whether the exam is going to postpone. Your exam is not going to be postponed. Believe me. So your exam is going to be on time. And please study hard. Okay, don't think about all these unnecessary things. Focus hard and make use of the last 10 days, which is very, very important. Revise thoroughly and go with full confidence for your exam. Okay, we'll all be praying for you, all the faculty here. So do well. So don't be frustrated or don't be scared during your exam. That is the most important thing. If you are scared, you are going to make silly mistakes. We don't want that. So please be confident and go for your exam. Okay. So all the best. All right then. So thanks guys for taking time out and joining me. So if you want to revise something, you can just look at the video once again. Anyway, I'll be giving the PDF, annotated PDF to the Arise technical team. They will send you and they will put it in the group. Okay, don't worry about it. So all the best and good night. Okay, bye.